There are real barriers to receiving mental health care for healthcare workers, not just imagined ones, right? Like there's stigma and there's discrimination. And also that the environment is really tough. And it's tough for reasons it has to be tough, right? Like you're taking care of other human beings on the worst day of their lives. But it's also tough for reasons maybe it doesn't have to be tough, where the environment of care is not designed for the humans involved, either the patients or the healthcare workers, frankly.
Welcome back to Tell Us Why, a podcast about and for the healthcare workforce. Thank you all for tuning in. I'm Jen Wright, and I'm thrilled to be joined by my new co-host, Renee Shore. Our veteran listeners will remember Renee from a previous episode when we explored the necessity of supporting the whole well-being of the workforce. Renee is now the project director of statewide employee retention and well-being with SCHA. Renee, it's so wonderful to share this space with you as we once again dive into systemic strategies that shape the healthcare workforce experience.
Thanks, Jen. I am so excited to be here. For our listeners, we are going to continue today by going into that deeper dive with how we intentionally realign harmony between the work itself and our extraordinary healthcare workforce that does that crucial work. So, Jen, today's conversation really hits at the core of that, and I would love for you to introduce our guest.
I would be more than happy to. Our guest today is Dr. Stefanie Simmons, an emergency medicine physician and the Chief Medical Officer at the Dr. Lorna Breen Heroes Foundation. Stefanie is a true national thought leader in healthcare worker well-being, leading massive structural shifts to improve the operational environment of care and dismantle barriers to mental health access. Stefanie, we are so incredibly grateful to have you here with us today. Welcome to Tell Us Why.
Thanks, Jen and Renee. I'm thrilled to be here.
So, Steph, to get us started, we always love to ask our guests about their why, their personal why, their professional why. And with your background as an emergency physician who then stepped into this massive advocacy space, we would love to hear your personal why and your professional path that brought you and led you to the Dr. Lorna Breen Heroes Foundation. And then what are the whys that keep you there doing this essential work every day?
Thanks for that question. This is really it's a story of expanding spheres and expanding understanding. So it really starts with my own story and those of the residents and the medical students, right, immediately around me. And then expands out to really a greater understanding of what others are going through. So I'm a bit of a non-traditional student, although I think maybe increasingly so. We're recruiting folks with more of my background into medicine than were happening when I went in, as I was a history major as an undergrad and just really interested in the big forces that sort of conspire to force action and force change in society, and came to medicine with that perspective of like, how do we both intervene at the personal level with the patient in front of us when these forces have caused injury, illness, right? But also then, is there the opportunity to be a cause, to be a driver, right? To improve health. And so that was why I went in and med school. And I went to med school thinking I would be a family medicine doctor. I love the idea of taking care of patients from birth to death and getting to know them deeply and sort of bending that curve of health for them. It's a good thing we rotate through all of these different. I found out pretty rapidly, like clinic was not for me. I needed a different pace. And so I matched into anesthesiology, and because I loved the pace of the critical care aspect. I loved the procedures. I loved the birth to death, pregnant people, like everybody. And I loved the shifts. Like I loved going to work, working intensely, and then leaving and being off. Right. And so I started residency in anesthesiology, and about 2/3 of the way through my transitional rotating year, I did an emergency medicine rotation. And I fell in love because it was all the things I loved about anesthesiology plus stories and stories of patients. The teams were often fairly highly conserved, meaning like you'd see the same people every time that you'd be working alongside when you went in. And it was really powerful to be able to care for people on the worst day of their lives with a team of people that you knew and loved.
Wow.
And so that's what brought me to emergency medicine. And at the end of my emergency medicine residency, I think like many people near the end of residency, you're exhausted. One of my attendings said, residency is like a kidney stone. It hurts a lot, you bleed a little, and then it passes. which is like, I was at the UPJ junction, at the end of where the kidney stone was about to pass,
right.
At the end of residency. And I had a really bad case. I was also pregnant with my second child. So I had 2 babies during residency, which is like, love those kids.
Yeah.
Would not necessarily recommend that life choice to others, but, I was really glad to be starting my family. I had peripartum depression with my second child. So it was during pregnancy and after pregnancy. And right around that time where I caught a really terrible case. It was a pediatric death, which in and of itself is awful for everybody involved. And the parent of that child ended up having caused that child's death. And so in addition to caring for the child and mourning her loss, comforting the parent, I then had to get involved with the legal system testifying in the murder trial.
Wow.
I was angry. I was angry for that child, and I was angry for myself because I felt like a sort of an innocence almost, or an openness to my patients and their families had been taken.
Yeah.
And that coupled with the peripartum depression, it was like a spiral. I was just about to end residency, and I knew that I was going to be asked about a history of mental health care, diagnosis, or treatment when I credentialed, when I got my permanent license, and I chose not to get help. Instead of completing the RWJ Clinical Scholars Fellowship that I had matched into, I dropped out of it. I went to work part-time for the community site in my residency, and it took me years of sort of clawing back to the place to really be on firm ground again. And that process took longer than it had to because I didn't get help, although I did land in a very nurturing clinical environment. That certainly did help. So that was my personal sort of origin and interest. And then I started really being open to the stories of folks around me, people who are experiencing temporary disabilities or mental health conditions or burnout or physical disabilities. And just like there was this stigma against A, talking about it, B, getting the support they needed, C, like a recognition that they were still valuable, independent, wonderful, like members of our profession and the healthcare team. So I was offered a role as the quality and safety director for my medical group about 2-3 years out of residency based on some work that I was doing in the Keystone Quality Initiatives. And I said, I will happily help you recruit somebody for that role. I've got some great ideas. And what I'd like to do is be the director of patient and clinician experience for this group because there isn't one. And
I love that.
Needed.
Yeah.
So, I was offered the opportunity to write the job description for that role. And once you're in a role where you have the privilege of hearing the stories of other colleagues, you realize how ubiquitous this is, that everyone has an experience of being a healthcare worker And we're all human. So they're all human experiences, it turns out, and we all need help. So that's sort of the long, shaggy dog answer to your beautiful question. But yeah, that's my why.
Well, thank you so much for sharing the depth of that story and the vulnerability it must take every time for you to share that, especially to folks you've just met. I mean, there's so much courage in doing that. And one of the things that I got out of your story that I respect so much is your own self-awareness of like, thank you for thinking of me for this great role. However, I feel like I would be better suited for this and that I could add greater value in this role. And you said, I think 3 years into your, that's a really strong leadership quality to have so early on in your career, so I bet you get to share that as well. So we're grateful for you sharing your story. So you landing at the Lorna Breen Heroes Foundation, the way I understand it, one of the foundation's missions is to fundamentally reduce burnout and safeguard that fulfillment so that clinicians seeking mental health care is something that is seen as universally a sign of strength. Mm-hmm. And that pairs so beautifully with our why framework and the focuses on work-life harmony, connection, and community. So I'm wondering if you could talk a little bit with us about the genesis of the foundation and how Lorna's legacy continues to drive that national systemic change rather than just targeting the individuals and saying, here's some self-care practices for you.
Yeah. Thank you for the question. And I also want to be aware, some of your listeners may have known Lorna, right? Because healthcare is it's a community. And so, Lorna was an emergency medicine physician, the director of emergency medicine at New York Presbyterian Allen Hospital in Manhattan. She was called back from a family vacation to take care of her community, but also her colleagues in the first days of the COVID-19 pandemic. Because as a medical director, right, she was trying to figure out how to keep people safe and to spin up the protocols and the procedures and we all have a mental image of what Manhattan looked like in those first weeks of the pandemic. Mm-hmm. Yeah. And that's what she came back into. And she worked 16, 18-hour shifts trying to do that work. She got COVID. She was sick with it. She came back like many people did 24 hours after her fever broke, exhausted, and became even more exhausted mentally, physically, emotionally, to the point where she couldn't get out of her chair. And she was evacuated by car to Virginia, which is where she grew up, where she received mental health care. And at discharge, one of the things she expressed to her family was that now that she had received mental health care, she was going to lose her license. She wouldn't be credentialed at her hospital anymore. Her leadership career was over. And Lorna died by suicide. 12 hours after her death, the New York Times published a story about her life and her death. And what happened next is that first dozens and then hundreds and ultimately thousands of other healthcare workers from around the entire ecosystem of healthcare, physicians, yes, but nurses, pharmacists, dentists, they reached out to first her family and now the foundation to say that Lorna wasn't alone in these concerns, that there are real barriers to receiving mental health care for healthcare workers, not just imagined ones, right? Like there's stigma and there's discrimination. And also that the environment is really tough. And it's tough for reasons it has to be tough, right? Like you're taking care of other human beings on the worst day of their lives. But it's also tough for reasons maybe it doesn't have to be tough, where the environment of care is not designed for the humans involved, either the patients or the healthcare workers, frankly. And so the foundation was really designed to address both sides of that equation, to reduce barriers to mental health access but also to help change healthcare environments to be more human-centered.
Wow, fantastic. Yeah, that always, stories like that always remind me, and please forgive me, I don't mean to make light of the situation at all, but it reminds me of, if you're familiar with A League of Their Own, and they are talking about, right, kind of a universal way to connect, right? Great movies. But Jimmy Dugan says, of course it's hard. It's the hard that makes it great. And there are, like you said, there are innate things about healthcare that are hard, and they're going to be hard. So can we soften the things that don't have to be hard so it's easier to deal with the hard?
I love that. And, just carrying that theme forward, the thing that makes the hard doable are the people, right? So the people on the team all come together and support each other. The coach supports them, right? And it's a pretty unwelcoming environment that they're doing their work in, and it can feel that way and be that way in healthcare too, where like the very communities you're serving can be rejecting the care, and we're seeing rise in that and in healthcare and violence against health workers. And so the solidity of those teams and the resources available to them become even more important. Absolutely.
Yeah, Stefanie, hearing your why and hearing Dr. Breen's story, like there's this echo that I have: protection from harm, right? Or do no harm. It's that oath, that commitment. And healthcare, we know that harm, we're not talking about something that's just physical, right? Harm it's cultural, it's interpersonal, it's administrative. And the work that you do is tremendous in exposing how we have an invasive credentialing and licensing application process that has historically treated mental health history almost like it's some kind of misconduct. So I would love if you could share what the foundation is doing in that space and how the mission and the commitment is to actively removing those barriers, those systematic breakdowns, so that clinicians can feel safe, right? Protected from harm when they seek care, and safe from, a personal security and safety standpoint, but also safe from a career standpoint too.
Yeah. Thank you for that question. And I want to go a little bit into like what these questions have looked like historically, how they can be changed to be less stigmatizing, and then how the foundation has been accelerating the pace of that change, which was underway where we were here. So I'm just old enough that when I credentialed for the first time, these questions were still under a category called moral fitness questions. I think in most applications that label has been eliminated, but it was moral fitness questions. And it was, have you ever been convicted of a felony? Are you a pedophile, or have you been convicted of exhibitionism? And then, have you ever been diagnosed or treated for a mental health condition? And I mean, it's like guilt by association, right? So it's that, have you ever been diagnosed or treated for a mental health condition is being grouped with felony convictions and pedophilia. It's being labeled as a moral failing. And the implication is that if you have sought care or been diagnosed with a mental health condition, that definitely is in a different category of your fitness to practice than any other possible cause of impairment. So how do we, and these questions, by the way, they're found in licensing, they're found in credentialing, they're found on payer applications, they're found on malpractice applications, and we're working to change it everywhere they exist. So what's the purpose? Like, why are these questions there? What's the purpose of them? And do they fulfill that purpose? And then I will say the answer is no, they don't. But I'll go into that. And then, so, okay, how do you ask a question that fulfills the actual purpose intended? And how do you make that change? So The purpose of these questions is to protect the safety of the public and to protect the organization doing the application, the credentialing or licensing application. So they're intended to protect the public by appropriately flagging an impaired clinician so that they can either be removed from practice, meaning they don't get credentialed, they don't get licensed, or they can receive resources to become no longer impaired. Mm-hmm. In practice, people with a history of diagnosis or treatment of a mental health condition are not more likely to be impaired than anyone else. In fact, given that everyone who practices healthcare is human, that's 100%. There are very few 100%, but 100% of people practicing healthcare are human. And we know between 1 in 2 and 1 in 5 humans will develop a mental health condition or a substance use disorder. We would be summarily eliminating up to half of our workforce if we said everyone with a history of a mental health condition or a substance use disorder is not fit to practice. We don't want to do that. A, we can't, and B, we shouldn't. So what are we really getting at? Are we trying to identify people who are currently impaired from practice? And if so, why don't we ask that? Why don't we ask, are you currently impaired from practice for any reason? Mm-hmm. And by the way, by asking just about mental health and substance use disorder, we're missing impairment for other reasons, like physical impairment or cognitive impairment, right? So just ask one question about current impairment that doesn't single out mental health and substance use disorder apart from physical and cognitive health. So are you currently impaired for any reason? It's actually a broader question and more specific to the needs of protecting the public. And people say, well, won't people lie about whether they're currently impaired? I was like, well, why were you comfortable asking and assuming people wouldn't lie about a history of mental health or substance use disorder, but you aren't comfortable about asking about current impairment. So there's like a double standard. So by changing the question to one single question about current impairment for any reason, we protect the public, we protect the organizations, and we protect health workers who now can seek care, diagnosis, and treatment without fear. Right. There's another layer to this, which is we also need systems in place to help people who have impairment, right? So we can talk about that separately, but it's a yes and in there.
Exactly.
So when the foundation first did our first map, and the first map that we did was for medical licensing, there were 17 states that we were able to confirm had best practice language in their medical licensing applications. Why had these 17 states made this change? Well, some of the medical licensing boards had independently said, like, we don't feel like we're asking this question the right way, it's not appropriate, and they had changed it. Also, the Federation of State Medical Boards, the AMA, and the Federation of State PHPs had put out white papers and best practice guidelines, and some of the states had made this change. What we did is we made a map, and we said, here's where this change has happened. And we gave a badge. And we said, if you have made this change, you get the seal of approval. In the 4 years now, since that first map, we've gone from 17 state medical licensing boards being consistent to over 44. Okay, so that it accelerated the pace of change. We've also made maps for nursing, pharmacy, dentistry, and those boards are beginning that change as well. Then we worked with hospitals and health systems and clinics and freestanding ERs and said, we know what the best practice language looks like. We've developed a toolkit. We'll audit your form once you've made the change and give you suggestions for other places you could improve the language. And then once you meet that best practice criteria, where your application, your reapplication, and your peer reference forms have eliminated language about past diagnosis or treatment, We'll give you the badge. We'll put you on the map. And so we've been able to verify over 3,000. Sorry, I almost gave us a power of 10 error here. Over 3,000 individual organizations that have made this change, hospitals, health systems at the largest scale, but also clinics and ERs and employer groups. And now we're starting to see for the first time malpractice insurers come in and making this change as well.
That's really incredible.
Mm-hmm.
These changes have impacted over 3.35 million health workers.
Amazing.
Incredible. Yes.
Really, really impressive and so necessary.
Well,
go ahead.
I'll tell you my decision at the beginning of my career not to seek help when I needed it was because of fear of what the repercussions would be of getting help on my career. It was a rational economic decision with partial information, right? So in addition to making these changes, we need to make sure that people know that the changes are happening. The health system that I worked in, the state that I worked in when I was graduating from residency, neither of those applications ask that question anymore. And so someone in the same position that I was 18 years ago would not have to worry about being asked in those settings.
Yeah, that communication piece is so crucial because that's the piece that helps the fear subside and helps the stigma be stomped down. It's one thing to put something on paper. It's a whole nother thing to actually feel it in the environment in which you work. Both for your company, for your team members, all of those things. So switching a little bit kind of to burnout and fulfillment, thankfully, it's becoming more universally accepted. Certainly we've known because of the data, but now becoming more accepted that burnout is an occupational syndrome caused by chronic unmitigated workplace stress and moral injury. And we've kind of officially hit the ceiling on the individual coping strategies. So when you're looking at that day-to-day environment of the clinician that we were just speaking of, what are some of the primary systemic or operational challenges that the foundation is trying to fix to protect the workers from the chronic overload?
I love the framing of this question, and absolutely agree with the definition of chronic uncontrolled stress without appropriate compensation. It's and by compensation I mean individual compensation for the stress, not pay necessarily. It's the first workplace environment aspect that needs to be addressed is that people need to have the time and space to actually deploy those individual resilience strategies that they know they need to do, right? So when I present to residents, like I would never recommend to a resident that they get 8+ hours of sleep a night at the same time in like a cool, quiet room. It's like, it's not available to them. Right. And so there are parts of sort of best practice individual behaviors that we're just not able to do. And so as the first thing that the operational environment can do is to optimize individuals' opportunities, do those individual behaviors, not tell them to do something that they're then prevented from doing by the environment. So that's number one. We also need to look at the efficiency of work. There's not a single person who goes into healthcare expecting it to be easy to take care of people who are sick or dying or in pain, right? Like it's hard. That's, and that can wear on you and that can require processing, right? Those are traumas, care for others.
Right.
It's not typically the thing that's wearing people out. It's the pebbles in the shoe. It's and that's part of a quote by Muhammad Ali that is, it's not the mountain ahead that defeats you, but it's the pebble in your shoe, right? It's small and not so small inefficiencies in getting things done. And part of those are societal, how we as a society pay for and organize our healthcare. Part of them are payer driven. Part of them are organizational. What are the resources, the processes that an individual organization puts in place? And part of them are team-based, particularly that like proximate manager. What is your one level above manager? Well, how are they talking about things, making decisions for you, et cetera? And then some of them are individual ways of work. So at each of those levels, there are opportunities to find efficiencies, to structure things to be human, and not let the tail wag the dog. So what do I mean by that? Well, we have goals of patient safety, of billing, of, being able to maintain our organizations fiscally, to have, enough patient care to maintain the organizational integrity. That's the tail, right? It's not the whole point. The whole point is human beings taking care of human beings. And when we are designing processes to allow for billing and maintaining the regulatory environment that we need to, and keeping our hospitals open, like if we're building processes for those that actually harm the human beings involved, then they're being built on a foundation that doesn't work. And so we need to help organizations, systems, society, policymakers make decisions that keep the human factors of the work environment centered in that decision making.
Kind of that ultimate layered approach.
Yes. And look at so for any given person, where can they make that change? What is their sphere of influence? And I think that's what's been so frustrating for many individual health workers over the years is their sphere of control and sphere of influence is largely in those individual resiliency behaviors. And that's all they're being talked to about. And they're like, okay, I got it. It's important. Yes. And it's something we always need to keep in mind, even when we've optimized. It's something you can keep revisiting. And how about your sphere of influence and control, organization? What part are you going to play? Are you going to ask me what the pebbles of my shoe are? Are you going to work to remove them? Are we in a partnership here where I'm doing my part and you're doing your part? Or am I just being asked to do more and more and more to take on the burden of this environment?
Awesome.
Well, I think when organizations make that commitment, right, and they take that stance, it speaks so loud and true to mattering at work, which is another one of our why core principles, right? One of our foundations. And another display of mattering at work is the impact for well-being guide that I'd love for us to touch on. I don't want to take that opportunity. So, Steph, as the primary advisor to the CDC's, I'm going to get this right, NIOSH, I'm going to ask you to define that for us, for our listeners first. But you were a primary advisor for that impact for well-being guide for healthcare leaders. So how does that guide give administrative leaders and organizational leaders the tools, the foundation for how they can pivot from maybe the traditional concept, right? Or maybe even the superficial, if I might, concept of wellness, and transition it into changes that really make our staff feel genuinely valued and seen and appreciated.
So NIOSH is National Institute for Occupational Safety and Health, and most healthcare workers will know about their NIOSH N95 badge, or a mask, N95 mask. So is occupational safety and health. And as we think about occupational safety and health, I'd like to harken back to your statement before. It's like, first, do no harm, right? And so we need to minimize the harm of the environments of care, just like if you were talking about minors, right? If you've got, you need to minimize the inhaled particulates, right? To remove the pulmonary disease. Same thing for health workers. The healthcare system poses a risk to work within, and we need to mitigate those risks. So, so the Impact Wellbeing Guide is a component of that risk mitigation. It was originally designed to be an awareness campaign funded by the Dr. Lorna Breen Healthcare Provider Protection Act for clinicians and healthcare leaders about burnout. And when the initial phases of the awareness campaign were completed, the feedback was loud and clear. Healthcare workers say, thank you very much. We know about burnout. We need solutions. And they can't be individually resiliency based. And healthcare leaders said, we hear a lot about burnout. We need things that we can implement to make change. And the time for talk is kind of over on this. So the Impact Wellbeing Guide was designed to be a very action-oriented guide. If you're being asked to work on professional well-being for your healthcare workforce, it feels a little bit like you're being asked to fix the U.S. healthcare system this Tuesday, right? It's like, that's like, it's so broad.
Massive.
And so where do I start, right? Where do I start? So the Impact Wellbeing Guide is designed to be, okay, you've been asked to eat an elephant. Like, here's the first 6 bites. And by the way, here's also a list of the people you need to invite to the elephant eating party with you to get this job done. And guys, I'm a vegetarian, so I'm not sure where this metaphor went. It's like, it's a big job and people need a guide. I think it's also worth mentioning at this point, like, healthcare leaders are also experiencing burnout. Absolutely. And so as much as we can provide structured technical assistance, guidelines, benchmarking, ways of getting this work done, the better. Okay, so the Impact Wellbeing Guide was designed as 6 steps. They are included with like collateral or guidelines on how to do them. So, a grid to fill out, for instance, as you think about your existing operations, a charter for what a well-being committee could or should look like, ways to do the credentialing change. So it's understanding your current hospital operations. It's convening a well-being team that's interprofessional and cross-disciplinary. It's removing barriers to mental health access. And that could be by providing mental health resources or eliminating credentialing, stigmatizing language, or both. It's communicating. And the communication is bi-directional communication, meaning listening and hearing what healthcare workers are telling you needs to change, but also making sure you're communicating about the changes that you're making. Because it can feel like, you're surveyed about what needs to be changed in your environment and you give your responses, and then you may or may not actually see those changes happen, but the loop is closed about what has been done, what hasn't been done, and why. So it's bidirectional communication. Then actually leveraging the quality improvement infrastructure of an organization to make professional well-being change. And I want to go back to that one at the end, but then the 6th one is to make a strategic plan that includes measurement, includes, integrating professional well-being metrics into QI, and includes peer support, a way for people to connect with each other. So that's sort of the content of the Impact Wellbeing Guide. And then we piloted it in a health system, and we found out something really important. Organizations can use this guide to make change, and there are so many competing priorities happening at any time in the life of a hospital or a health system that it really helps if the organizations are put into community with other organizations making the same change. And so that's that's why we built the Caring for Caregivers communities to help do that.
Nice.
I'd love to go back to this idea of like QI infrastructure though. So
please do.
Every healthcare environment has quality improvement projects going on all the time. And there's a quality improvement methodology, and there's all different kinds. There's like, the plan, do, study, act, PDSA cycle, there's lean, there's Six Sigma, there's like lots of different ways that people do quality. That same approach can be used for professional well-being work and needs to be approached for professional well-being work, because we need to be intervening in ways that are measurable, justifiable, and sustainable. Otherwise, they become the first thing on the cutting floor when budgets are tight. And we also may be investing resources in something that isn't really helping people. So we need to make sure that we are approaching professional well-being work with the same rigor. We can actually use the infrastructure that's been built for quality improvement, just shift it 10 degrees and view it through the lens of professional well-being. You can also measure the impact of quality improvement projects on the healthcare workforce, which sort of instantly transforms every QI project you have going into a professional well-being project, right? So that frame shift, I think, was new for organizations in a lot of cases, that this isn't a tack on to your core operations. This needs to be woven into your core operations.
Absolutely. And I love that reframing that structure gives it the rigor and the evidence-informed plan that everyone's looking for sustainability, for validity. And so, that's one of the things that I love about the why framework is the workforce experience survey is built as a tool to not only elevate the voice of the workforce and provide an organization with the opportunity to close the loop, but it gives that kind of action-oriented recommendation with it to resources like the Dr. Lorna Breen Heroes Foundation to make it happen. And I want to assure our listeners today that just like all the other conversations that we have with our highly esteemed guests, what Steph's talking about today is evidence-based. It's evidence-informed. There's data to back it up. So if you're looking for approaches that are rooted in evidence, this is part of that conversation. It just happens to be human-centric in nature. So, I came across recently kind of a fascinating yet heartbreaking data point that I feel like today is a good day to highlight, which is, while the vast majority of physicians, and I think we can probably open that up to clinicians as well, say they would completely support a colleague who seeks mental health care, those same physicians assume that they would be judged harshly if they themselves sought help. So from your perspective, Steph, how do we bridge that trust gap and build that kind of localized culture of genuine psychological safety within a health system?
So we did a survey with the Heart of Safety Coalition of groups of physicians, nurses, PAs, NPs, and that was actually one of our findings was this gap between what people would want for their colleagues and what they would do for themselves. It's interesting though, because we also asked the same group if they would judge a colleague negatively if they received mental health care. And for physicians, 1 in 10 physicians would judge a colleague negatively if they received mental health care, and 1 in 20 nurses, NPs, and PAs would. So I think in order to explain this gap, you need that data point because it explains the gap. There is I know I would not judge you, so I would want you to disclose to me and feel safe and comfortable with me. But I don't know whether you are one of those 1 in 10 or 1 in 20. So I don't feel safe disclosing. So how do we get over this issue? Well, there's 3 ways we get over it. The first way is if you are one in 10 or 1 in 20 people who would negatively judge a colleague for receiving mental health care, you've got some work to do on yourself. Because you need to think, why am I a health worker when I am negatively judging people for receiving health care, period. And to me, it's a fundamental disconnect that you need to resolve in your own self. Mm-hmm. So that's one thing that's going to make the change, is people having the introspection to do that. Mm-hmm. 2, if you are someone who is positive about mental health care, thinks everybody should have mental health care, everybody deserves that, should be free to talk about it. If that's your belief, you need to declare yourself as an ally to people before they are sharing with you. So they know that you are someone who is safe to talk to and to share it with. And I would say doubly or triply so if you are in a leadership position, because it takes that internal calculus of, are they safe or not, off the table, and then they can just talk to you. Mm-hmm. The third thing that needs to happen is people who have sought mental health care, who do have a diagnosis or a history of treatment, need to start disclosing appropriately in professional settings. Mm-hmm. We are starting to increasingly see people who are in leadership positions who are safer do that disclosure, and that helps to break down the stigma. Mm-hmm. So here I am, perfectly functional, great clinician. Mm-hmm. Heck, the other day you said great catch to me in the hallway on the patient that, you signed out to me that I found something. Like, I'm a doc, I'm a leader, and I have a mental health diagnosis and treatment history. For people to hear that and to know that, it starts to break down that stigma, and also helps people who do have a diagnosis or treatment see themselves and their careers in a positive light, which is how they should be viewing themselves, their careers, right? So those 3 things all need to happen. People need to work on themselves. Mm-hmm. People need to declare themselves as allies. And for people for whom it is safe, need to disclose. And we're seeing those 3 things happen.
Yeah, I love that we're having this conversation, that we're taking this opportunity to highlight these person-centered wins, these victories, right, that the foundation has for us. Everything from influencing, credentialing and licensing language for millions, how many millions of healthcare?
5 million.
How many millions of healthcare workers, right? And then the distribution of the well-being impact guide, reauthorization of the Dr. Lorna Breen Healthcare Protection Act. But for executives that might be joining us today, or that are sitting around the table and they need this to make a business case, right? They need to make this make sense from a business standpoint. How do we explain the VOI, right? The value on investment, when we are prioritizing, mental health and these safety nets for organizations and for systems?
Boy, I wish I had like a very straightforward plug and play, do this program, you will experience this ROI for your organization. And those tools are starting to be built, by the way, as people are measuring in a more sophisticated way. I can share a few of the data points that we've gotten back from organizations that have implemented changes in credentialing. And then I want to also challenge those leaders on measurement. So we sent out a survey to all of the health systems that had done the credentialing change and received the badge. And we asked, how's it going? We've heard from health workers that this is important. Logically, it makes sense.
Right.
Is it worth it? What have you seen happen? And we asked in the positive and we asked in the negative, like what bad things have happened and what good things have happened. So this is the only time I've ever seen this happen in a survey. There were 0 negative results. So no one said there was a negative impact on quality, safety, risk, compliance, anything. 0. People saw increased utilization of mental health resources, which to me is a strong story about how there was a need that was not being filled and is now being filled.
Absolutely.
Definitely.
Positive sentiment from the healthcare workforce at that organization about the change. Wow, you guys actually changed something that matters to me. This very clearly expresses the organization cares about me. You've made this change and it matters. Okay. And some organizations also reported an increase in retention. People said, I don't want to leave this place. You guys are doing good things. Okay. So we have evidence for the credentialing change that it matters. It increases employees who need to get care, getting care. And it also sort of increases positive sentiment, intent to stay, et cetera. So for that, there's that evidence. We also know what clinicians say are perceived barriers to care. And so we know how to design mental health access that then once people are safe to access it, they actually can access. Like it's the right person, it's the right hours, it's the right place, it's the right cost, all of those things. In terms of the value and investment of other interventions, whether that's a rigorous electronic health record discipline where you are being efficient and you are getting feedback and you are making sure that the inbox is efficient for clinicians, that charting is efficient for clinicians. You need to measure the right thing in order to be able to develop your own organizational VOI for the project. And where a lot of times the ROI calculations fall flat is they are looking only at increased efficiency.
Absolutely.
Like, is this AI charting intervention, does it pay for itself and increase efficiency? Well, that's really just making the hamster wheel spin faster for those healthcare workers, right? And so we need to think about, does it pay for itself? Is the value that we're getting in terms of increased engagement, retention, patient experience, clinician experience, are all of these factors together making the implementation of this worthwhile value to the organization? And the answer may be that it is of value in some subsets of clinicians and maybe not in others. But we're starting to see measurement-based organizations that can really start to parse out some of the complexities of measuring value and impact of well-being interventions. And that ability to measure really discreetly some of the leading indicators of professional well-being, like time in chart or pajama time or actual versus scheduled hours, like those leading indicators, the actual professional well-being directly surveyed of the healthcare workforce, and then the lagging indicators like turnover, intent to leave, intent to reduce hours, quality and risk data, et cetera. Like we need to have a sophisticated way to measure well-being that takes into account both the leading, direct, and lagging components. That's where we're really going to be able to capture the value on investment that healthcare workers feel when there is a comprehensive infrastructure around professional well-being. It's not that it's not there, it's that it's difficult to capture because we are looking at those data, the leading, lagging, and direct data, as separate from each other and as in different silos within the organization, where a comprehensive modular dashboarded approach is really required to fully understand the value of investment.
Part of what I'm hearing you say is, really making it real, like trying to put a value or a number or a scale on the experience, on the environment that the healthcare worker is either thriving in or having to try to survive.
So value on investment ends up being an advocacy question more than anything else, right? You're saying, how do I advocate for these programs to grow and remain?
Yes.
And so you need three things: heart, head, and a path forward. So in this work, the heart part is pretty straightforward. You capture the stories of the people who've been positively impacted by the program. This was important to me because here's my story. And if that's an actual human being actually telling their actual story, right, it becomes very powerful. That's the heart. The head is, what are the data? What's the utilization rates? What's the impact? What's the change? How does that impact our metrics? What's the cost? All of those things are the head, heart and head. And then the path forward is, okay, here's the balance of those two and a recommendation. And it may be that we're losing money on this program, but it is in the short term, right? But it is of immense value in improving the engagement and the well-being of our workforce, with ultimately may lead to improved retention, outcomes, et cetera. Or it might just be the right thing to do, mitigating risk to the healthcare workforce of the environment. So that might be a path forward, or it might, hey, this coaching intervention reduces our turnover by 20% for every, turnover risk by 20% for every person coached. The return on investment is concrete and 20x for the program. Let's grow it. So there's there's different ways to look at and talk about value on investment versus return on investment, whether it's fiscal or human or story-based or spreadsheet-based. And you kind of do both, all, in order to be a great shepherd of this work within an organization.
Well, that might be one of the best descriptions of value on investment that I've heard in a very long time. So really, really appreciate your insight on that. And just kind of emphasizing that path forward. We touched on this a bit earlier in our conversation, but how do we move beyond that policy on paper to changing the behaviors that the clinicians are experiencing every day? So for those hospital division presidents, nurse managers, clinic directors, and maybe even just that one level above manager you mentioned, what are actionable behaviors that they can implement, this afternoon, tomorrow, that help their teams understand that humanity matters more than productivity?
I want to be very careful in how I answer this, because each of the people that you mentioned is also under extraordinary strain,
right?
And experiencing extraordinary burnout. In fact, the only group that has more burnout than healthcare workers is their unit level managers and leaders,
right?
And it's a yes, and they have all of the stressors of providing healthcare, and then they're also responsible for the management. So the real answer, if there's one thing you could do, it would be self-compassion and recognizing that you're doing an extraordinarily difficult job, and you're a human being, and you also need to be aware of your own needs and limits, because you cannot give what you don't have. And just like we can't ask a frontline health worker to give to a patient what they don't have, we can't ask a leader to give to their teams what they don't have. So it's an unsatisfying answer, because there's also lots of things after that I could talk about, but it's disingenuous not to recognize the humanity of the leader as well.
Well, and I do think that's incredibly powerful. We're our own worst critic. So if we can show ourselves compassion, not only does that put us in a better headspace to help others, but that's a great model, right? If we want our teams to have self-compassion and compassionate courage to lead forward, we need to model that behavior. So I think that's an inspiring answer.
If you're a leader and you're not taking your own PTO, just think about what message that sends
right
to your team. Like, here's what the expectation is, and I can't find a way to take it. So how would you be able to do that?
Absolutely.
And so that, I mean, that's one thing, take your time away. Don't make being busy a badge of honor.
100%.
How often is the answer to how are you doing? Oh, I'm so busy. That somehow means you're being effective in the world, showing up the right way for the people in your life, or accomplishing a lot. It's actually could mean that you're not doing any of those things. So how powerful would it be to how are you doing today? You know what? I'm feeling pretty calm and relaxed. I've cut down my work to focus on one important thing today. I'm going to make sure I get that done, as a leader. And then what's the one important thing you want to make sure happens for each one of your patients? Right. And now I understand there's 80 things that needs to happen for every patient, right? You need to examine them. You need to put the labs in. You need to follow up on the x-ray. Those all the things. But what's the one thing you want to make sure happens for that patient? A, I want to make sure they get the correct diagnosis and treatment. And B, I want them to make sure that they feel seen and cared for. So all of the other things I do have to be to serve those two aims.
Yeah.
Right? So that's the revolution in healthcare is not wearing busy as a badge of honor, and thinking about every decision that is made, whether it's a bedside decision, a management decision, a leadership decision, a strategic decision, or a board decision, right? Every decision in healthcare is around centering the people involved, the patients, yes, and all of the healthcare workers and leaders in the organization as well.
Amazing.
Yeah. I want to make sure too, Stefanie, we talk about that path forward. Our listeners have the heart and they have the head. And so I want to make sure that we impart on them what next or what now, right? And so for our listeners that are looking for that path forward, what's your advice? What are the recommendations for, when they say, I really want to, I want to bring this toolkit, this advocacy to my own health system, right? Or what advice or recommendations can you give them for how they get involved and show support for the foundation and the resources it offers and maintain that connection to their work? What advice would you give them, and what do we do next?
Okay, so you've done self-compassion and now you're ready to act. Got it. The good news is we have a lot of great resources. So if your organization is not already a Wellbeing First Champions Challenge, we have a toolkit, we have a audit process, and we will recognize your organization as a Wellbeing First Champions Challenge once you made the changes to your applications, if there are changes that need to be made. That process is free. Including the badge and the communication toolkit that comes out with it. So I would encourage any organization, check to see if you're already a champion. If you're not, do that work.
Free definitely piques some.
Yeah. In a lot of things, healthcare, there's that 2x2 grid of effort and impact. This is in the exact right quadrant of relatively low effort and cost and high impact for an organization. So this is a just do it. If you are an organization who is interested in going deeper in your professional well-being journal, look at the Impact Wellbeing Guide. You may already be doing some parts of it, but there may also be, and there probably are, parts of it that are learning for you, particularly around measurement. Read it. It's not super long. It's not a 287 page tome. It's a guide. So look through that and see what you can implement. And in the Impact Wellbeing Guide, there's also a list of references and opportunities to go deeper. And there are many different ways to go deeper. One way is our Caring for Caregivers communities, which are learning collaboratives of organizations that are going through the Impact Wellbeing Guide together. So they're doing credentialing change. They're doing an organizational assessment of their well-being infrastructure, and then they're working in a learning collaborative together to implement a change. So right now we have learning collaboratives in that are complete in Virginia, underway in North Carolina, in Wisconsin, in Houston, and our first ever national collaborative that organizations can participate in. So that's also an opportunity. That organizational assessment of professional well-being infrastructure is called the Breen Scale. Right now, it's available within our Caring for Caregivers communities, but in 2027, it will be available outside of those learning communities. So that will be another opportunity for individuals and organizations to really understand where their opportunities are and where they can mature within their organizations. Mm-hmm. And then I would say the Lorna Breen Heroes Foundation is a philanthropically supported organization. And so if you or your organization or a foundation that your organization supports or that you're on the board of is interested in supporting and advancing the work of the foundation, that's another way to support us, is to help us with that financial support.
This has been so insightful. I really hate to wrap us up, but I have to just say, Stefanie, thank you so very much for telling us why. Your clarity, your empathy, and your fierce dedication to rebuilding the system from the inside out are exactly what healthcare needs right now. A couple of my takeaways from today are crystal clear. Our clinicians are human beings first, and their worth completely transcends their productivity. And fixing this isn't only about individual clinician tools. It's on all of us to redesign the system so it protects everyone better. So to our audience, thank you for listening. To learn more about the Why Initiative and how we're working to build fulfilling workplaces, please visit scy.org. To dive into the life-saving work discussed today, you can check out the episode notes and head over to drlornabreen.org. And this is my final episode co-hosting Tell Us Why. It has been a true joy to share the microphone with all of our guests, my co-hosts along the way, Emily, Beth, and Renee. Ladies, thank you. And thank you to Kyle, our producer, for taking such great care of all the behind-the-scenes production. I am so grateful to have been part of bringing this vision to life. I'm handing the reins over to two incredible workforce champions, Renee and Annie. Please keep tuning in for more vital conversations.
Jen, we are so incredibly grateful for your vision and the legacy. You've left us with big shoes to fill, and we will do you proud. And we know we will see you back. We know we will. We know that you'll be listening in. And so thank you for the opportunity and for the guidance that you've given us.
It has been my pleasure, and you will absolutely not be getting rid of me. I will be listening and always willing to come back as a guest. You are in very capable hands, listeners. They will do a tremendous job. And if you loved this episode, please leave us a review, share it with your colleagues, and subscribe so you never miss a future episode. Please take care of yourselves, and we'll see you all next time.